Hello everyone. Welcome to our scientific series. I have the pleasure to have with us Dr. Anita Koushik. Donc, depuis août 2023, Dr. Koushik est professeur au département d'oncologie de l'Université de McGill, chercheur au centre de recherche de St. Mary et aussi la première titulaire de notre chaire de recherche de l'Université McGill en oncologie communautaire. Auparavant, elle était professeure d'épidémiologie à l'École de santé publique de l'Université de Montréal et chercheur au centre de recherche du CHUM. Elle a obtenu un baccalauréat en pharmacologie de l'Université d'Alberta et une maîtrise en santé communautaire et épidémiologie de l'Université Queen's, un doctorat en épidémiologie et biostatistique de l'Université McGill, puis a suivi une formation postdoctorale au département de nutrition de Harvard School of Public Health. Son programme de recherche vise à mieux comprendre l'étiologie du cancer afin d'améliorer la prévention primaire et les efforts d'évaluation des risques. Ses projets se concentrent sur les facteurs liés au mode de vie. Elle mène également des recherches sur l'identification des facteurs modifiables susceptibles d'améliorer le pronostic et la qualité de vie des survivants de cancer. Merci.
All right. Well, thank you everyone for being here. The title of my presentation is Lifestyle Across the Life Course and Ovarian Cancer Prevention. And I found this nice graphic about that represents a life course, a female life course in particular. So I may be sorry about that. I might have pressed mute twice. So just mentioning, to recap here, cancer is the leading cause of death in Canada, accounting for almost 26% of all deaths in Canada. And with the second one being much less at 17.7%, that's heart disease, which is actually the leading cause of death in the US. So we're a little bit different in that sense. So cancer is very important with respect to mortality, but there are a lot of other consequences of cancer, including the physical impact of a diagnosis, pain, nausea, fatigue, psychosocial consequences that happen to the patient themselves as well as their family members, and also an economic burden, even in Canada, actually. So the societal cost is estimated to be at about 26 billion in Canada in comparison to about 20 billion for heart disease. There are personal costs related to many different things, medical time as well as productivity. So all of that to say that cancer prevention is very important. And in particular, there are different types of prevention, but I'm talking about primary prevention, which is aimed at preventing the occurrence of cancer in the first place. And to do that, we need to know what increases or decreases the risk. So identification of risk factors. So what do we know about cancer risk factors? This was a study done, I think it started in 2015 to determine, it's called the COMPARE study, to determine all of the knowledge we have on cancer risk factors, how much can we prevent? Like what proportion of cancers are attributable to the factors that we know about. And from this, it was estimated that about 4 in 10 cancer cases in Canada can be prevented either through healthy living or through policies at the governmental level that would protect Canadians. So what are these factors? So these are the different factors. The circles represent the impact they have on causing cancer. So you can see the largest circle is tobacco. Cigarette smoking has a huge impact on cancer, which means that if people didn't smoke, it would have a huge impact on the incidence rates. Second is physical inactivity, excess weight, dietary factors, sun, HPV, some other infections, And then some environmental factors like radon and air pollution, indoor tanning. So we see here that.
So we have a little audio problem.
Okay.
Can people online hear us? Can someone?
Yes, we can.
Okay, perfect. Okay, thank you. Just
Okay.
okay.
Thank you. Okay, so yeah, so this is what we know about cancer, but as I said, only with all of this knowledge, it still is 4 in 10 cancers that can be prevented. So this all comes from cancer prevention research, epidemiologic research, and it is challenging to study cancer risk factors. So I just want to talk a little bit about the features of cancer that has relevance to research. First of all, it is a disease of aging. People age 65 and more account for 60% of all new diagnoses. It is not that aging is a risk factor per se of cancer. In fact, it's thought that aging and oncogenesis share common mechanisms and they kind of work in parallel. You might have heard, I'm going to talk about this at the end of the presentation, about early onset cancers. Even with more younger people getting cancer, it still is a disease of aging. Another feature of cancer is that it is multifactorial, which means that many different factors will cause the disease. And not only that, it's many different factors together. So, we've probably all know or have heard of the person who smoked for 60 years and died from a fall, never got lung cancer, even though there's this high attributable risk of lung cancer with smoking. But it's because there has to be that whole constellation. So these are what we call causal pies in epidemiology for oral cancer. So, one person might get oral cancer because of smoking, alcohol, low fruit consumption, and some sort of genetic susceptibility. Another person, age, genetics, not seeing the dentist, and HPV. And what the idea here is that you need all of these in a given situation to get the cancer. If you're, have tobacco, alcohol, low fruit, but you don't have genetic susceptibility, maybe you won't get it. So basically, cancer is caused by multiple factors, environmental and genetic. And then in general, the more often and longer one is in contact with these factors, the greater chance that cancer will develop because you might be exposed to one of these other factors. So putting this all together, this is the challenge I wanted to mention, is that there is a long induction period for most risk factors in causing cancer, multiple decades. And what does induction period mean? It's looking at this graph. So, you're exposed to, low fruit and vegetables. And this is the period where it's important, like where there might be some genetic mistakes that might become, a mutation, that it could be repaired if you had good fruit consumption, but you didn't do that. And then causal action is complete. Then there might be some DNA repair mechanisms, but then if you're exposed to others, you start smoking or something like that, you might outweigh that. And at some point, cancer will begin because all of the risk factors have come together. So that's the induction period for a given risk factor, the time when, okay, fruits and vegetables were important until now, and now cancer might develop if you have these other risk factors. And then after that, cancer begins, but cancer is rarely diagnosed as soon as you get it. Usually there's a very long latency period because the symptoms take a long time to develop. And so given all of these things, you can see that cancer, it just takes a really long time to develop. And so that's where the challenge comes in the different studies. And actually, I'll show you in the next slide. So I first want to mention these, what I consider to be landmark studies in the identification of cancer risk factors. The Nurses' Health Study, the Health Professionals Follow-Up Study, they were both ran out of the Harvard School of Public Health. And then the cancer prevention studies that were done by the American Cancer Society. And there are many more, but I'm just mentioning these ones because they were very much focused on cancers. And they're all prospective cohort studies, which means they recruited a population, and you can see how large the populations are, 120,000, 50,000, 180,000, recruited them, determined whether they were exposed or not to whatever the factor might be. Let's say it's low fruit and vegetable, or just fruit and vegetable consumption, high versus low. And then they're all at risk of cancer, so they don't have the cancer yet. And then they're followed to see who gets cancer, to see if people who have high consumption, fare better than the people who have low consumption. And with cancer having a long period to develop, an induction period, you can see how the study has to be very long. And when you're following 120,000 people or 180,000, even 50,000 people, these studies cost millions of dollars per year. And you might have actually heard that the NIH has cut funding for the follow-up of all of these studies, actually, which is quite a shame. So, because of that, though, what these studies did is the baseline age, the age that they recruited the participants, sorry, they're not patients, they're healthy people, were, relatively old, let's say. We had what were the risk factors and ages. Like this one was the youngest one, where they had people as young as 30 years old, but up to 55 years old, 40 to 75 and 40 to 92. So this is a much more efficient way of getting this information in a shorter amount of time, knowing that we have to follow people a long time for the development of cancer in another within the study. And so this is what has led us to knowing about 4 in 10 cancers can be prevented, but it would be nice to get that up to 10 out of 10, right? So I mentioned the age group here. So we know what's going on in sort of early to middle adulthood. Actually, I would say it's middle to late adulthood, because the majority of the populations were older than this. But early life might be important, even early adulthood. And this is where I'm coming at with this with this presentation. So there is evidence showing that early life exposures are important in cancer risks. Some things that we know very well about, such as early age at menarche, which is associated with an increased risk of breast cancer. Even a late age at menarche is very young, in the whole life course. Another one we know a lot about is the fact that human papillomavirus infection is a necessary cause of cervical cancer. You have to be exposed to get cervical cancer. And that infection is usually acquired in adolescent or early adulthood, but cancer develops much later. And another interesting example is exposure to diethylstilbestrol in utero. So this is the pregnant women having taken that, their daughters having an increased risk of cancer later on. So this is actually in utero exposure. So we do know that early life can play an important role in the development of cancer. So this is where my research program, what motivates my research program, let's say. So I'm going to present to you on lifestyle factors and ovarian cancer risk, where we really took a lot of attention on exposure timing over the life course. A little brief background on ovarian cancer. It's the 8th most common cause of cancer in females in Canada, but it moves up the ranks in terms of cause of cancer death, being ranked as 5th cause of cancer death, with a 5-year net survival of about 44%. The average age of diagnosis is about 63 years, with about 2/3 being diagnosed at age 55 or older. And most cases are diagnosed at late stages. We do not have any screening methods that can work at a population level, so there's no screening program for ovarian cancer. Treatment has improved, has been effective, but as I showed you with the survival, it still is quite low. So primary prevention is key, and that requires knowledge of risk factors. So what do we know about ovarian cancer risk factors? So the left side shows the risk factors that are established. We know that they are related to ovarian cancer risk. So the first one is a family history, mostly related to genetic factors associated with an increase in risk. The second two, oral contraceptive use and increasing parity, are established to reduce the risk. And these are more modifiable, sort of, but also not really, because one is not necessarily going to have pregnancies for the purposes of cancer prevention. The other factors, breastfeeding, menopausal hormone therapy, obesity, and talc, they have been associated. Breastfeeding has been associated with a reduced risk, independent of parity, actually. But overall, what we can see here, this is what we know about, and there's not many risk factors that we know about. But what is interesting is that the two modifiable established risk factors, or actually preventive factors, of parity and oral contraceptives, they generally occur in early adulthood. So it is possible that the induction period that I talked about earlier for a potential protective or risk effect of other exposure occurs over several decades and at least as early as adulthood. So that has been a focus of many of the different projects that we have conducted in this study. It's called the PROVAC study, which is a population-based case control study, which we conducted in Montreal. So the study base was the Greater Montreal area. We recruited participants between 2011 and 2016 for a final population of 498 cases, women with ovarian cancer, and 908 controls, people without ovarian cancer. We conducted in-person interviews that assessed many different things: sociodemographics, pregnancy, menstrual history, other medical history, some family history, a whole occupational history, and also many, many different lifestyle factors, where for all of these, but especially the lifestyle factors, they had to recall their exposures over their adulthood. So that gave us the ability to know about risk factor exposure during different times in the life. And of course, recall is very difficult. So we use something called a life events calendar, which gets people to mark down important life events and the date of them, because it cognitively helps people to remember other different things, less of an impact in their life. So this following slide shows my obsession with looking at exposure timing and lifestyle factors and ovarian cancer risk. First of all, in purple are the various different lifestyle factors we have examined. So some dietary factors like caffeine and alcohol intake, vitamin D, I guess, and then body fatness and physical activity and shift work and sleep. So these are all the various types of lifestyle factors that we have examined. And then we've used different types of methods. So I did mention that, there's this induction period and different exposures might have an effect at different times. If you only examine or assess exposure at age 35 or age 50, we're getting exposure at age 50, but if cancer takes a really long time to develop and, 55, you get cancer at 55, it's probably not exposure at age 50 that has caused the cancer. It's probably something before. So those landmark studies probably could have missed something. So if you look at the average lifetime exposure, which is what we did for shift work and caffeine intake, it's not specific, but it will capture what we think would be what we call the etiologic window, like the window of when that exposure has an important influence. So that's one way we have addressed exposure timing, but then we've refined our methods as we've gone along. One is to look at age-defined exposure periods. So we look at the average over the lifetime, but then we also look at alcohol intake between 15 and 19, alcohol intake between 20 and 44, and try to see if there are differences in risk according to when the timing of when, like based on age, when they were exposed. And more recently, we've taken more sophisticated statistical methods. One developed by one of our colleagues here at McGill University, Mikhail Abramowicz, using the weighted cumulative exposure model, which is a very interesting way to look at, basically get the data to tell us what weighs more heavily time-wise in terms of the development of ovarian cancer in this case. Another way of also representing exposure over the life course is to see if there are any trajectories that people follow. Another statistical method. So this one we did with body fatness, looking at how essentially how weight changes over time between ages 20 to 70, for which we had data for. And then finally, the other method that we've used is the Bayesian relevant life course exposure models. It was also developed by a researcher here at McGill, Srinath Madhatil. And that's what I'm going to present to you on today. So our exposure, our data on body fatness and total physical activity. And these were led by Jennifer Ratanja over here. And so all the great slides are by Jen, like this one. So just a little bit of background. Why are we interested in adiposity and cancer risk and ovarian cancer risk? Well, first of all, we do know that excess body fatness is a risk factor for many cancers. such as postmenopausal breast cancer, colorectal, liver, endometrial cancer. And mechanisms by which this may happen include insulin resistance, IGFs, inflammation, oxidative stress, and generally an effect on sex hormones, which are very important for ovarian cancer. And we know that adipose tissue itself is an important source of sex hormones, especially in the postmenopausal period, but even earlier on. And so the hypothesis is that excess body fatness at any or different times during the life course may be associated with ovarian cancer. So in terms of previous studies that have examined adiposity in ovarian cancer, in fact, there have been many studies, over 50 studies. They have used body mass index as a proxy measure of body fatness. In general, BMI, increasing BMI is related to increasing health concerns. This graphic over here shows the normal categories that we usually examine. So based on these 50 studies, ovarian cancer is actually considered one of the 13 cancers considered as obesity related. But this is based on a relatively weak positive association with a relative risk of 1.06 for each 5-point change in BMI. So a 6% increase for a 5-point change. That's actually quite weak. But when you pool a lot of data together, it's statistically significant. So, and it is, 6% is not nothing, but it's kind of weak, right? And what it is that in these 50 studies, almost all of them, it was recent BMI that was the measure of exposure. But that recent BMI, the participants were in their middle or late adulthood. So were they capturing the etiologically pertinent time? And what's interesting is that a few of those studies actually asked people to recall their weight at younger ages in early adulthood, about ages 18 to 20. And most of those did suggest a positive association, a stronger positive association than what was seen for middle to late adulthood. So the other exposure we examined is physical activity, and it's possibly related to the same mechanisms with the role that physical activity has on adiposity, but also physical activity can have a direct role on estrogen secretion metabolism. And so the hypothesis here is that low physical activity increases ovarian cancer risk. And in terms of previous studies, actually the results are very mixed. The relative risks have suggested that physical activity increases your risk, decreases your risk, or has absolutely no association. So we need more research to see what's going on, especially given particular limitations. One of them is that almost all the previous studies focused on recreational physical activity, but physical activity is also derived from routine activities related to occupation, active transport, or housework, gardening, things you do at the household, which were not measured in these studies. So there might have created noise to their measure of physical activity, and that's why the results are inconsistent. And then the other thing is, again, most studies measure physical activity in middle to late adulthood and not necessarily captured an earlier time in life. So the objectives here were to examine exposure to body fatness and physical activity levels over the life course, in particular the adult life course, because this is what we collected data on, in relation to invasive ovarian cancer risk. Assessing the question, does timing of exposure influence risk? And the specific aim, I'm going to come back to it because I'm going to define it for you, but it's to identify the life course hypothesis that best explains the association with ovarian cancer risk later in life. So first of all, I want to introduce the life course approach to epidemiologic research. It is a formal methodological, formal methodology to examine exposures really over the life, like for whatever you have data for, in relation to whatever outcome. Here we have a very nice graphic again, thanks to Jen, showing, it could be infancy, adolescence, adulthood, older age, the post-menopausal period. We can define many different things and consider the different exposures or the same exposure that might happen during different times of life that might change or that might stay static. It allows for everything, actually. So the framework we used in this study was the female hormonal life course, given the intimate relationship between hormones and the ovary. This is a graph that just shows what sort of happens to the main female hormones, estrogen and progesterone, during the life course, the female life course. And actually, a lot of research attention is given to the periods of puberty and perimenopause because there's so much change during that time. It's considered that the reproductive years hormone levels are stable, but they're not really stable because pregnancies change things, breastfeeding changes things. If you take oral contraceptives, that actually changes your endogenous hormone levels as well. And again, as I mentioned, pregnancies, breastfeeding, and OCUs are factors that occur in early adulthood. Menopausal hormone therapy also stabilizes this, and that's in later adulthood. So the timing of these experiences might be important for ovarian cancer, and therefore the timing of exposures to other things might also be important, whether it be through an influence of these exposures on hormones or by other mechanisms. So we defined 3 life course periods for this study. So we studied the early reproductive years, the later reproductive years, and then this peri and postmenopausal period. And partly because of data availability, I didn't have data on adolescents. And as I mentioned, that specific objective was to identify the life course hypothesis that best explains the association with ovarian cancer risk later in life. And so what does life course hypothesis mean? This is a very nice graphic that sort of shows it. We have, like I said, 3 different life periods. The different hypotheses are the life accumulation hypothesis, the critical period hypothesis, the sensitive period hypothesis. So this life accumulation hypothesis would say that exposure at any time during your life is equally important, and it just is an accumulation of exposure. So if you are, smoking, let's use that, smoking at any time in your life course, it's going to be a risk factor for whatever cancer that we're talking about. The critical period hypothesis says that it's restricted to this one critical period. So suppose you smoke your whole life. If you smoke during this period, that's when that's going to cause your cancer. You smoke here, it doesn't matter. You smoke here, it doesn't matter. You quit here, it doesn't matter if you smoked here, Okay, that's the critical period hypothesis. And the sensitive period hypothesis is saying that, yes, the whole life course is important, but there's a much stronger impact in one period. And in this particular example, the darker color is in the first life period. So this method allows us to examine which hypothesis is most relevant to our data. So again, we examined body fatness using body mass index as the proxy measure. So we had a measure for each decade of life, starting at age 20 up until study participation. And then we also examined total moderate to vigorous physical activity. So we had activity-specific energy expenditure for activities in all of the domains. So recreational, occupational, transport, and housework. And again, from age 20 to the year of study participation. So I'm not going to go through all of this. Bayesian statistics are very cool, but I just want to just tell you what methods that what I'm going to present in terms of results. So we use the odds ratio to estimate the relative risks. That's because this is a case control study. So basically that was it. The odds ratio here reflects the impact of the relevant life course exposure on risk. So it's one value that represents the whole life course. But as I mentioned, we wanted to know whether there's a critical period, a sensitive period, or is it equal across? We wanted to know, essentially, in other words, the relevance of exposure during those 3 defined life periods. So this method also estimates the weight for each of the life periods, and which reflects the relative importance. We use this Bayesian framework, and what that gives us, instead of a confidence interval, we get something called a credible interval, which is nice because what it does is it presents the range of values that that represents a probability that whatever, the parameter of interest lies within that range with that certain probability. And, we usually use 95%. And so the parameter of interest, again, were the odds ratio and the weights. And then I'm not going to talk too much about our confounder method, but we identified a confounder set as well. Okay, so in terms of the weights, so again, going back to those 3 hypotheses, this is what we would expect to see. The weights should always add to 1. So if it's the life accumulation hypothesis where exposure at any time in life is equally important, we would have 0.3333 plus, so same weights, and it would be 0.333, whatever, repeating. Critical period hypothesis, it would mean that the weight is 1 in that one period and 0 in the others. And then the sensitive period hypothesis would be larger in 1 or maybe 2, I guess, versus others. We can have 2 sensitive periods. Yeah, but anyway, in this example, it's larger in 1 versus the others. Okay, so start with some results. In terms of the population, we were studying invasive ovarian cancer and the controls, and there was matching. So they were similar in age, 62 years. Most of them were postmenopausal. The cases were more likely to be nulliparous and to have never used oral contraceptives. That's what we expect, given that these are 2 very important factors that reduce risk. And also their education level was a little bit lower than the controls. In terms of our 2 variables of interest, we did see that body mass index actually did increase over the different life periods. Here are 4 different life periods. And total physical activities. So actually, we've published on body mass index, total physical activity, our analyses in progress, but we have some results already. So physical activity levels increased and then decreased past the age of 50. And this, as I mentioned, we had data on all the different domains, and most studies in the past have only focused on recreation. And we see here in looking at total physical activity that recreation is not accounting for the majority of the physical activity that we can be exposed to. It's actually housework, according to the females in our study. Okay, so now for the results. So that odds ratio, it was 1.57. This is for body mass index, comparing 25 or greater versus less than 25, which is a cutoff often used to, the labels that have been used include like overweight and obese. So what this means here is that the lifetime effect of being exposed to higher versus lower BMI, it is associated with a 57% increased ovarian cancer risk over the adult course, life course. And so this credible interval says there's a 95% probability that the result is between 0.84 and 2.8. 2.8 is a very strong relative risk. 0.84 is almost no association or possibly a protective effect, but a probability that we can calculate with this method is, the probability that the odds ratio really is an increased risk, and it was about 90%. So what this 1.57 lifetime risk it want to take account is that it takes into account the relevant exposure over the lifetime, which means the weights. So we do want to see what those weights are, but so remember, this is the expectation according to the different life course hypotheses. And this is what we see, which is 0.49, 0.32, and 0.19. So what it suggests is that BMI has a slightly stronger impact on cancer risk in the early reproductive years with a weight of 0.49 instead of 0.33, 0.33. So it suggests sensitive, the early reproductive years could be a sensitive period for the relation between BMI and ovarian cancer. And remember, I said all the previous studies had mostly measured late, some middle adulthood. And so these are the preliminary results for physical activity. Here, the comparison is, again, high versus low. If you have any questions on what that means, I can answer it later. And here we see a strong protective effect, actually, the lifetime effect indicates a 43% reduction in ovarian cancer risk. For high versus low, the probability that the odds ratio is less than 1 is almost 100%. And you can see that the 95% credible interval does not even include 1, which would indicate no association. And then looking at the weights, this is kind of interesting, but we actually see that physical activity has a stronger impact on cancers in the later reproductive year, with the weight being higher versus the other 2 periods. Okay, so to summarize the results, high versus low BMI was associated with an increased risk, and a sensitive period was suggested for the early reproductive years. And excuse me, high versus low physical activity was associated with the lower risk, with the sensitive period seeming to be in the later reproductive years. So to contextualize our findings, as I mentioned in previous studies, BMI was associated with a 6% increase in risk, well, for each 5-point change in BMI. So our findings are consistent with a positive association as well, but it expands on the current evidence by suggesting a sensitive period in the early reproductive years for invasive cancer. And remember that most studies BMI was measured in the peri and postmenopausal period, which may be the reason that the association was weak across the previous studies. And then to contextualize our MVPA results, well, as I said, previous studies were all on recreational activity and they were inconsistent. So our findings are new, and they suggest that MVPA may be associated with a reduced risk, and particularly during later reproductive years. So that could be the interpretation, but we should also always consider methodological issues. As I mentioned, we had participants recall the activities they participated in, their weight at different times in their life. We do expect error, but this error most likely would have biased results towards the null, which means that the real results might be stronger than what I presented. I didn't mention this but you might have noticed on my slides, participation rates were not 100%. So one thing to also consider is selection bias. We do know that those who refused were older, they had lower education level, and they smoked more. So one way of dealing with this is to include these variables in the models, and we did. But if there are any other factors related to selection bias that were not included, then they would not have been adjusted for. Confounding also is something that we have to take into consideration. In our causal models, we considered a number of potential factors, but of course, it's all based on what we know, the literature. So if there's anything that we don't know about, that's very important, that would have been missed. The biggest concern would be the precision that we had. We had very wide credible intervals. Our analyses only had about 360 cases and 700 controls. So that has to be taken into consideration. So to really summarize it, I think our findings highlight the potential importance of considering exposure timing across the life course. And they also suggest that a sensitive period in early and or later reproductive years is a candidate life course hypothesis for further investigation of what we've investigated, which is body fatness and physical activity in relation to ovarian cancer. But I would also say to the study of lifestyle factors in relation to other cancers and these lifestyle factors, as well as other factors in relation to ovarian and other cancers. I think the life course is very important to take into consideration. And so just a few more thoughts there, which I think there are other important implications that are quite current, let's say. I'm sure you have seen the recent headlines over the last, 6 or 7 years about people dying of colon cancer and breast cancer at very early ages. Some famous people as well. That's why it kind of makes the news. So these cancers, they're called early onset cancers, defined as cancers that are diagnosed in adults between the ages of 18 and 49. And some factors related to this. So these are people that are people in this age group, they're too young for recommended routine cancer screening. So they're likely to be missed for that reason. Another characteristic is that certain cancers, for example, breast cancers, tend to be much more aggressive in younger adults. And then they also tend to present at a more advanced age, which is not solely explained by the delay in diagnosis, given that they're not screened. And I mentioned in my first 2 slides the consequences of cancer diagnosis, mortality, and the physical, psychosocial, and economic burden. But early onset cancers have even more to consider because they're young. So there's family planning. Some women might experience early menopause. Some surgeries might change things in terms of body image and sexual health. So it really is important that we start learning more about this and work on cancer prevention here as well. So there have been, so I showed you headlines, but there has been some research done as well. So this is this is a huge paper actually, which examines multiple different types of cancers. I just put the results for breast and colon cancer. So this shows the differences in, well, the title is Differences in Cancer Rates Among Adults Born Between 1920 and 1990. Basically, what this graph is saying is for estrogen receptor positive breast cancers, the lowest incidence rate was in 1930. So compared to the incidence at this point in time, the incidence rates in 1990 are about 1.86 times. So almost, approaching double the incidence that it was at this time. And what I want to point out, this is according to birth cohort. Sorry, it wasn't time. It was like the time that someone was born, actually. So people born in 1930 versus people born in 1990, they're experiencing a much higher rate. And I would like to point out that this paper published in 2019, or sorry, the data was up until 2019. These people were not quite 30 years old yet, so they're very young and they have the highest rates. And it's the same thing for colorectal cancer. So the lowest rates were in 1955. There was huge decline, like huge decline over time. And now when we look at these young, 30 and 40-year-olds, it's about 1.5 times the risk. So this does seem to be a real thing. This is US data. And this just shows the age-specific annual percentage changes in incidence between 2000 and 2019. So for everyone, people age 30, each year between 2000 and 2019, the rates have been increasing by 2% for breast cancer for 30-year-olds. And basically the incidence rates, they have been increasing straight across the board, but it's much higher for younger people. And then for colorectal cancer, again, it's interesting, but like the older people are still, seeing reductions in the rate each year, whereas increases in incidence are happening for the younger age group. So, it kind of matches those headlines that we've been seeing. So a review was done a couple of years ago. So the evidence does suggest that there is an etiological role for exposures early in life and young adulthood, but we don't really know what they are at the moment. But we do know that various different factors in early life have changed substantially over time, especially since the mid 20th century. So we talk about the obesity epidemic. A lot of environmental exposures have changed. Lifestyle has changed. We drive a lot. There's just a lot of things. The microbiome as well. This third bullet point is a scary thought, but the early onset cancer epidemic might be one manifestation of increasing trends in the development of many chronic diseases in young and future generations. So there's a suggestion that prospective cohort studies using electronic health records or early life biospecimen collection would, enable the detailed investigation of early life factors in relation to cancer as well as anything. And then they also call for, raising awareness of the early onset cancer epidemic and improving early life environment as immediate goals, because they are likely to reduce the burden of both early and late onset cancers. And then I would add that we should also continue life course epidemiology until we have these great data sets with the, electronic health records, because that's going to take a lot of time to collect, to have enough people to study. So, until recently, there were no studies, but actually one study was recently published using data from the UK Biobank. They calculated a health associated lifestyle score, the HLS, which is based on a combination of smoking, physical activity, alcohol, and diet. So just kind of your usual suspects for lifestyle factors. And what they do show, this is just for breast cancer, is that the unhealthy category is associated with a slight increased risk of breast cancer. So this was a small number of cases because, again, these are early onset cancers. There were like less than 400 breast cancer cases in the study, but it's trending towards, the fact that maybe we should be studying early life. Well, first of all, giving that message of having healthy lifestyle starting from a young age, and also maybe doing more research on that. So to end, my take-home messages here, going back to the beginning of the presentation, cancer epidemiologic research in primary prevention has made strides. We do know that 4 cancer diagnoses can be prevented through lifestyle and policy, but there's more to know. I'd like to see that 4 get closer to a 10. So what are other risk or preventive factors that we can take action on, and how can we address the rise in early onset cancers? So the consideration of exposure timing might help in risk factor identification, whether it be in the study of the usual suspects like diet, physical activity, etc., but also to identify and study novel candidate factors. And taking into consideration everything that is new. Technology has changed a lot too. And then there are interesting and sophisticated methods developed right here at McGill to address exposure timing. So something we can take advantage of. So the research I presented today was from a grant funded by the CIHR. As I mentioned, Jennifer has led all of these analyses. And then I mentioned my co-investigators. And of course, we used data that was already collected that was funded by the Canadian Cancer Society, Cancer Research Society. I had collaboration of so many different hospitals. And this is just some of the research personnel. So, and then also my personal funding, which was, FRQS, CIHR, and currently St. Mary's. So I thank you all. And if you have any questions.